Good afternoon to everybody. Welcome to the 23rd seminar of the seminar series Bridges, which is organized by the Hellenic Initiative Against Alzheimer's Disease. Today, it is a great honor for our seminars to host Professor Matthew Peters, who will deliver a talk about exploring the glymphatic system's role in traumatic brain injury-related neurodegeneration. Dr. Peters is Associate Professor at Johns Hopkins University School of Medicine. He holds dual appointments in the Department of Psychiatry and Behavioral Sciences and Department of Neurology. He completed his medical school training, psychiatry residency training, and neuropsychiatric fellowship at Hopkins before joining the faculty. He is currently the Director of Clinical Services for Psychiatry at Johns Hopkins Bayview Medical Center. Dr. Peters is an active clinician, teacher, and researcher. He sees patients in the Acquired Brain Injury Clinic and Memory and Alzheimer's Treatment Center at Johns Hopkins Bayview. He has been internationally recognized for his research work and has received research funding from the National Institutes of Health, Department of Defense, and National Alzheimer's Coordinating Center. His research focuses on cognitive and other neuropsychiatric symptoms following traumatic brain injury, with a specific focus on traumatic brain injury in older adults and neuroimaging-based biomarkers. It's actually a great pleasure for us to have today as speaker Dr. Peters. Dr. Peters, the floor is yours.
Great. Thank you guys very much. And it's very nice to be here. Thanks to everybody for the invitation, and to Kostas Laketsos specifically, who's been a mentor of mine for a very long time since I started my training, and was actually the one that let me know about this particular opportunity. So today, as already mentioned, we're going to talk about the lymphatic system and the role that it may play in TBI-related neurodegeneration. It's a topic that's actually quite fun to speak about. It's something that's increasingly recognized and discussed in the research literature. And we could go into great detail, but I'm going to try to make sure you guys get the basics for what this might look like, and then leave plenty of time at the end if there are questions that come up. No disclosures that are relevant to this presentation. I always say if something comes up during the Q&A, I'll certainly let you all know. So just a bit of background before we start focusing on the glymphatic system specifically. Historically, when you look at outcomes following traumatic brain injury, the general idea was that there was complete recovery days a week following a more mild TBI, and static deficits following a more severe TBI. The thinking about that has changed, especially in recent years. But before we get to that, in 1928, there's been a third entity that people have talked about in those with repetitive head injury and progressive neurodegeneration. This entity is now known as chronic traumatic encephalopathy. First spoken about really in the population of fighters or boxers, now discussed within American football players, especially within the National Football League, soccer players, rugby players, hockey players, and certainly continues to be discussed in individuals that are fighters, for example, the mixed martial arts guys. It's now also widely accepted that there's an association between even a single TBI, and that could be a mild one, in some individuals and the risk for future neurodegenerative illness. We know that the association is complex, and some of the reasons for that complexity is that brain trauma varies by cause, force, and direction. There are certain areas of the brain that are closer to bony prominences that are more likely to be damaged, but because you have a very heterogeneous cause and heterogeneous ways that the head can be hit, the damage from it varies quite broadly. And not only can the areas that are damaged vary, but the type of pathology that is deposited varies in individual cases. There are cases where amyloid beta are deposited, cases where tau gets deposited, cases where it's really neuroinflammation that seems to be driving things, but you don't necessarily see a ton of tau or beta amyloid. So it's difficult when you're meeting with an individual that's had a recent head injury or is aging with a head injury to know what actual pathology that person may have in their brain. Also, neurodegenerative illnesses have an insidious onset. So it's often decades between the occurrence of a traumatic brain injury and the onset of neurodegeneration. When we're seeing these patients in memory clinic, they're often telling us about injuries they had when in college, when in their 20s, their 30s, and they're coming to see us often in their 60s, 70s. And it's really hard for us to know what contribution that brain injury may be playing. And if you look at studies as they get conducted, you're going to need very long longitudinal studies to be able to look at what influence does a traumatic brain injury actually have on that onset of neurodegeneration. Also, TBI is associated with different neurodegenerative conditions. It's not just CTE, and it's not just Alzheimer's disease. We see an association with Parkinson's disease, with frontotemporal dementia. There is data to suggest that if the TBI is contributing in some way, these diseases might present with slightly different neuropsychiatric symptoms. So, for example, in Alzheimer's disease, somebody that may have a history of TBI might be more likely to present with agitation or disinhibition than if you looked at the general population without head injury. And then lastly, traumatic brain injury is more than just disease-based. So yes, you have that pathology that may be laid down in the brain, but it's occurring in individuals with different baseline personalities, different behaviors, substance abuse, difference in how healthy they are with their diet, and then certainly psychosocial circumstances vary as well. And when you have the occurrence of a TBI, it can, in some individuals, really result in a complete paradigm shift in where they're able to go psychosocially, or at least where they believe they're able to go. And it's often a very important part of that person's life story moving forward. So just to look at the glymphatic system and how it's been referenced in the literature in relation to TBI, we're going to go through this. It was named in 2012, and at this point, over 200 articles are published on the connection between the glymphatic system and TBI, and we're going to go through a bit of that literature as we proceed through the talk today. A lot of our thinking around this, we actually laid out in as organized a way as we could in an expert review that Kostas Liketsos and I did for Molecular Psychiatry. It's wild to think that was already 2 years ago, but we did a really nice look through the literature and tried to lay down at least the current understanding of what role this system may be contributing. And if your institution doesn't have access to the article, I'm certainly happy to send it to any of you. All right, so getting into the objectives now that background's out of the road, let's talk through the what and how of post-TBI brain cleanup, develop a basic understanding of the glymphatic system, examine how TBI may disrupt the glymphatic system, and then discuss trends that we see in the current literature. So the what and how of post-TBI brain cleanup, I'll try to keep relatively brief. What makes TBI different than other forms of brain injury are that you actually have a transfer of external force energy resulting in mechanical stress and damage. So this is a mechanical force impact that is going into the brain. And what it triggers is an inflammatory response that is non-infectious. There are things called damage-associated molecular patterns. They get activated when this mechanical stress comes into the brain. And an important thing to remember is that this force energy, it doesn't just go into the brain parenchyma, it goes into the meninges, the vasculature, the CSF, the musculature. So, you have different parts of the brain that are absorbing elements of this energy. And so you see damage in more than just the brain tissue itself. You see this increase in extracellular amino acids, especially glutamate. And when this is activating NMDA and AMPA receptors, you actually get some cell death that occurs following the acute injury. And that cell death itself is something that's important. And we're going to come back to the different chemicals that may lead to being deposited. You also see mitochondrial dysfunction and generation of reactive oxygen species. Again, this is another thing that can lead to cell death. And interestingly, you see this leakage of the blood-brain barrier and surrounding blood vessels. And what that can lead to is blood-based complement and cell-free hemoglobin is actually an irritant to the brain itself. So the blood-brain barrier exists. The brain does not want to be exposed to blood. And if you have this leakage, this by itself can cause a pretty intense inflammatory response in the brain. You have activated immune cells that arrive at the site of injury. These include astrocytes and microglial cells. The astrocyte part of this is you're about to see why that is so important. But obviously, these immune cells are coming to the site of injury. And what the brain is really doing is it's trying to balance the extent and duration of the immune response. There needs to be an immune response. Things need to get cleaned up. But if it's activated for too long, you can actually end up with some things that are not as productive and can potentially lead to more damage. Now, the diffuse axonal injury, this cell death that's occurring, what you have happen is a release of neurodegenerative proteins, phosphorylated tau, amyloid precursor protein, amyloid beta, all known to be released. As you guys probably know, more evidence suggesting that amyloid beta and phosphorylated tau can spread throughout the brain almost in a prion-like fashion. So if you have damage to a specific area of the brain from the TBI and you end up with misfolded phosphorylated tau and amyloid beta, that can certainly, it appears, transsynaptically spread from cell to cell and lead to a chain of ongoing neurodegeneration. So microglial cells, when you look up the kind of how of brain cleanup, they come in, they clean up damage through phagocytosis. They're trying to get these different proteins or molecules isolated and prevent them from continuing to irritate and drive a neuroinflammatory response. There's also targeted clearance across the blood-brain barrier. An example of this for amyloid beta, there's a low-density lipoprotein receptor that actually helps to move beta amyloid across the blood-brain barrier in a very meaningful, purposeful way. And then, of course, you have drainage through CSF efflux out of the brain. And this is going to be where really what we hone in on over the next 30 minutes or so is to think through how does CSF actually get out of the brain and what do we know about that process. CSF largely moves by bulk flow. You have the choroid plexus that's making new CSF. You have arterial pulses just from our heart beating that help to move CSF forward. And there's actually evidence that respiration as well with the changes in pressure help to drive CSF through the brain and through these various systems. So I'm going to just point out a few things on this slide. So looking down here where we have number 1 marked, this is how CSF gets into the superior sagittal sinus, goes up through arachnoid granulations, gets released into the sinus, and then goes out through the venous vasculature. This is the drainage pathway that even when I was in medical school, this is the one we knew about. This is the one that we focused on. The other 2 systems, the glymphatic system and the fact that the brain has lymph nodes and lymphatics, all of that is relatively new. So looking at the glymphatic system, which is what we're going to spend time on today, you see that you have this perivascular flow along these arteries that are penetrating into the brain. So you have cerebral arteries that become Peel arteries that become arterioles. And there's actually a space between the pia mater and these, which are astrocytes. And this is forming a basement membrane that actually creates sort of like a donut around the arterioles themselves. This space has been known for a long time. It's called the Virchow-Robin space. People have known it has existed. They have known that if you look at imaging and this space is enlarged, it could be a signifier of disease in the brain. So this space has been known. The fact that CSF flows through it and can actually clean elements of the brain through it, that's the part that is relatively new. So you have this one pathway, it's going in the direction of blood flow. We're going to come back to this astrocyte basement membrane, and it's on this side of the pia mater. So still separate from the bloodstream, and there are ways that it interacts with that. But for the primary thing for the group right now, between the pia mater and the astrocytic end feet. Now, there's a third system that lets you get into the meningeal and nasal lymphatics. This one, interestingly, goes against the flow of blood. It's in the actual middle layer of the arterioles themselves, the tunica media. So within the arterial smooth muscle, you have space that CSF can actually drain opposite the flow of blood. This only exists on the arterial side. Veins don't have that smooth muscle for pumping. And so this is a pathway that you can get, same thing, kind of interstitial fluid mixed with CSF up out of the brain and eventually into the meningeal lymphatics and the nasal lymphatics. So you have a drainage pathway going forward through the brain and to the venous system, and one that's going backwards actually along the arterial system and out into the lymphatics. And then you have the one we've known about for a long time, which is the superior sagittal sinus. So let's develop a basic understanding of the glymphatic system itself. Its name derives from the key role of glial cells, so astrocytes being the glial cells in this case, and its function as a lymphatic clearance pathway. It was really initially described in a marine model by Ilf and colleagues. This was in 2012. It is the article that everybody references when they're talking about the glymphatic pathway. And this particular research group, they did have an interest in how this related to traumatic brain injury. And so it's nice for my field of study that this really well-respected group that has done a lot of the foundational work, their interest is in traumatic brain injury. So they went on to publish another paper in 2014 where they showed that TBI can impair the glymphatic system, and it can lead to this deposition of amyloid beta and phosphorylated tau. So exactly the things that can drive neurodegeneration, and in many ways can make the TBI-related neurodegeneration look similar to Alzheimer's disease. So let's walk through fairly quickly the kind of four key parts of this glymphatic system. So as I already talked about, you have CSF that is coming in along these penetrating arterioles. It enters into the brain parenchyma in this way. So it's going to go through this astrocytic basement membrane, and it's going to actually get into the interstitial fluid. So you have CSF mixing with this clear watery fluid that fills the space between cells and tissues in the body. It will pick up, usually just by bulk flow and by diffusion metrics, it will pick up proteins, it will pick up, I tell patients sort of the garbage that your brain has generated during the day. This is one way that it gets picked up. And eventually it goes out the other side. There, in this particular pathway, is a similar space around the venous portion of the vasculature. Again, goes through those astrocytic end feet, so out of the interstitial space, back into the space surrounding the vasculature, and then out of the brain. And so that's the flow. Comes in along arteries, goes into the interstitial space, goes out along the venous route. And these aquaporin 4 channels that are on the astrocytes, we think that those are really essential to this process. If you look at astrocytic end feet and you look at the brain CSF interface and the brain vascular interface, there's 10x higher concentration of these channels at those interfaces than within the rest of the astrocyte. When you have neuronal activation and some of the, let's say potassium, for example, is being released into the interstitial space from that activation, when the brain is most active, the glymphatic pathway is a way of getting that fluid back into the brain and back into the cells. So you actually see the glymphatic pathway shrink when the brain is most active, and you see it expand when a person is at rest or a person is sleeping. And we're going to get into that as one of the trends in the literature. But you're largely, the hypothesis is that decreased norepinephrine levels lead to this expansion of the glymphatic space when an individual is at rest. So let's look at how TBI might disrupt the glymphatic system. I like to break this part out by what do we know from human research and what do we know from animal research. The in vivo human research is largely, and this was true in 2023 when we wrote our review, it's still true today. It's largely at the stage of validating imaging techniques that can study flow through this system. And although there are more imaging techniques than I listed here, these are the three that I wanted to tell the group a little bit about. There's an individual slide for each one, so I won't read them right at this moment. So as I mentioned earlier, these enlarged perivascular spaces have been recognized on neuroimaging for an extended period of time. You see these enlarged spaces in things like stroke, for example. You see them in people as their brain are aging, and they show up as almost these circles that you can see on imaging. In this representation, you see that there's an enlarged space around the arterial. Now that we believe and think that this is the glymphatic system or the space involved in the glymphatic system, they're starting to think of these enlarged space burden as an indication of lymphatic system disruption. It may be a bit hard to see on your screen, but if you look at this MRI image, you can see all these, they almost look like lines that are enhancing. The yellow arrows, I really tried to find a slide without them because I think they're pretty clear and the arrows actually distract from seeing them. But you can see these lines that are evident on the MRI. Those are thought to be these enlarged perivascular spaces and are now thought of as a potential indicator of glymphatic system disruption. One of the biggest issues with that is it almost certainly is an indicator of other disease processes. So how specific it is for the glymphatic system is fairly unknown. Another technique that is increasingly used is this intrathecal administration of gadolinium-based contrast agents. So same type of gadolinium agents that get injected into the venous system for contrast-enhanced MRI images, except in these cases, they're essentially doing a lumbar puncture and injecting it into the CSF, and it will eventually work its way through the CSF system and back up into the brain. So I unfortunately couldn't find a good example TBI picture of this, but this is a picture from a patient with normal pressure hydrocephalus, imaged at 2 hours, 4 hours, 6 hours, and 24 hours after gadolinium, intrathecal gadolinium administration. You see after 2 hours, you're starting to see some areas in the periphery of the brain light up. And then when you get down to 24 hours, you see this penetration down into the brain parenchyma. And the thought is that this is reflecting glymphatic system functioning. And then lastly, diffuse tensor imaging has also been around for a fairly decent amount of time. Because it looks at water movement, there are groups that are trying to use sophisticated algorithms to look at water movement along the perivascular space. So, and again, with the thought being that if it's along the perivascular space, it potentially is related to the glymphatic system. And what they look at is they compare the movement of water parallel to that space compared to movement of water perpendicular to that space. This involves a lot of image processing and algorithm work. I'm not the best at reading DTI to begin with, but I want the group to know that this is a fairly widely available imaging technique that they're applying sort of sophisticated algorithms to. And so it's reasonable to think that you're going to see some of that expand fairly quickly. So there have been some actual studies looking at this in traumatic brain injury now. So I give an example here of a study by Zhao et al. It was published in Frontiers Neurology in 2024. They looked at this enlarged perivascular space burden and this index on DTI that is supposed to simulate movement along the perivascular space. They looked at 44 patients with mild traumatic brain injury. They looked at them 14 days post-injury and then 6 to 12 months post-injury. And then they looked at orthopedic and healthy controls. For the enlarged perivascular space burden, they used an existing algorithm that searches for a minimal cluster size around the vasculature itself. So, is that space enlarged enough to meet their minimal cluster criteria? And then for the DTI along perivascular space index, they again used an existing algorithm that looks at movement of water through the perivascular space versus a direction perpendicular to it. Now, I just want to put the takeaways, not all of which are really related to traumatic brain injury. So one of the things that they saw is that enlarged perivascular space burden and these changes on DTI exhibit significant correlations with age. So a higher number on this ALPS index indicates better movement through the glymphatic system. So you look at controls, mild TBI at 14 days and mild TBI 6 to 12 days. Even just with age, you see a decrease in the flow through that pathway as somebody ages. And the flip side of that, if you look at these enlarged perivascular space burden as a percentage, so a higher percentage is going to be more burden and theoretically worse flow through the glymphatic system. Again, in controls and at both TBI time points, correlates with age. No correlation with TBI by itself, just this age correlation. And we will get into some of the TBI correlations in a second. So elevated enlarged perivascular space burden at that 14-day point was correlated with a higher number of post-concussive symptoms. So they did think they saw some correlation with symptomatology. It did not also correlate with the DTI index. So I think in an ideal world, you'd see the same correlation in both of them if they're supposed to be looking at the same thing. But in this study, it did not. What they did find with the DTI is that when you look at improvement in sleep from the acute to chronic phases of mild TBI, you actually, as your sleep improves, the flow through the system seems to improve as well. Now, from what I said earlier, that would make sense. If you're getting better sleep, then the glymphatic pathway should be functioning in a better way. And in fact, sleep disruption after TBI is one potential target to improve flow through the glymphatic system, and something that we're going to talk about when we get to different trends. And then lastly, if you put these two measures of glymphatic functioning into a receiver operating curve, you get an improved representation of 6 to 12 month memory problem prediction. In model 1, they were focused on clinical and sociodemographic variables, largely being education and MRI and CT findings. And then in model 2, same thing, but they added in that enlarged perivascular space and DTI measure as well. So let's look at some animal research quickly. Just in summary, this is what has been found in the animal research, and then we'll walk through 2 specific studies as well. So decreased flow through the glymphatic space has been observed after traumatic brain injury in animal research. Loss of polarization of aquaporin 4 on these astrocytic end feet. Aquaporin 4 knockout appears to be a double-edged sword. So If you knock this out, which is going to change the flow through the glymphatic system and impair it, if you knock that out in the short term, you may actually help with some immediate cerebral edema following more severe TBI. So that would argue that some of the flow and expansion of that interstitial space might be related to increased flow through the glymphatic system. But if you impair the system's ability to do some cleaning afterwards, then you see exacerbated protein aggregation in the long term. There's also decreased clearance of proteins involved in TBI-related neurodegeneration, as we mentioned earlier, amyloid beta and phosphorylated tau. And when they've looked at blast exposure, as one might expect, you might see a more diffuse disruption in the glymphatic system following a blast exposure as opposed to a blunt force impact. So let's look at an example study. So this is a mild to moderate closed head injury model. This is the Ilfadal paper from 2014. It was published in the Journal of Neuroscience. In aquaporin 4 normal mice, they exhibited a 60% decrease in glymphatic pathway functioning, and that persisted for up to 28 days post-injury. And if you take a look at the actual tracer influx into the cortex, so these are 30 minutes after injection of a tracer. If you look at your sham mouse, you see that it is getting out there into the cortex itself. If you look at your TBI post-injury mouse, here's the impact site. It's very dark. The hypothesis would be that the glymphatic system is disrupted. You're not getting this flow down into the brain. But also very importantly, is that on the contralateral side, you see the same thing. You also see a decrease in tracer uptake, and you see sort of a more diffuse decrease in it. So I want you to remember, from a glymphatic system disruption standpoint, may actually be both sides that get disrupted. Now, when they knocked out aquaporin 4, there was further impairment in glymphatic functioning and increased accumulation of hyperphosphorylated tau, axonal degeneration, and decreased neurocognitive functioning, again, in a marine model, not in a human model. Now, the reason I wanted to highlight that the tracer infusion makes it appear that both sides' glymphatic system may be disrupted. When you look at deposition of, and I believe this is the hyperphosphorylated tau one. Yes, it is. So this is hyperphosphorylated tau immunoreactivity in the cortex and the striatum. This is wild type. This is aquaporin 4 knockout. So even though you might have some disruption of the glymphatic system on both sides, the side where you had the impact appears to be the side where you have some accumulation of proteins. So contralateral side is these sort of smaller bars, ipsilateral side, the higher one. So to me, this means glymphatic system may be disrupted on both sides, but the area where most of the damage occurred is on that ipsilateral side, and therefore the impairment in glymphatic functioning, it's kind of more devastating on that side because you're not able to clear out these proteins that have been released. So to wrap things up, let's discuss a few trends in the literature. As many of you probably know, sleep disruption is very common after TBI. It occurs in 30 to 70% of individuals. Those with sleep disruption after TBI have poorer recovery trajectories, more post-concussive symptoms. This is just looking at some metrics from our traumatic brain injury clinic. And when you look at just the number of people with abnormal sleep time, sleep efficiency, sleep latency, wake after sleep onset, I mean, you're running 40 to 70% on each of those individual metrics. And if you look at, actual metrics of the sleep cycle itself, also a decent amount of abnormality as well. And just looking at our clinic population, all I really want you to know is when you put all those parameters together, the median number of abnormal ones that these people have is 5 out of 12 parameters. So the sleep disruption is a very big deal after TBI. And as we just have been talking about with the glymphatic system, that potentially means that their ability to clear out TBI-related damage might be disrupted as well. So there was a nice study in marine models. This is Zhu et al., 2013, published in Science. What they found is that in marine models during sleep, the interstitial space expands up to 60%. Non-REM slow wave sleep, the actual oscillation that occurs appears to drive oscillations in blood volume and appears to drive movement through the glymphatic system. CSF production increases during sleep, so you have more of that initial force to drive bulk flow of CSF. And amyloid beta is cleared at a faster rate during sleep. And one important thing to note when you look at this, this is clearance of amyloid beta when the marine model is awake. This is when it's asleep. And then this is when it's anesthetized. So what makes this so interesting from a potential treatment standpoint is it doesn't look like this is just circadian rhythm related. It looks like even in an induced type of sleep, you may get improved clearance of these concerning proteins from the brain. So this is another study. This is Plog 2015, Journal of Neuroscience. And what they did is they manipulated the glymphatic system in a number of ways and looked to see what that did to clearance of TBI-related biomarkers. The reason why I highlight this and I think it's so important is that as we've worked to develop TBI-related biomarkers, there is no coexisting measure of glymphatic system functioning that we're usually looking at, and I hope this explains why that might be a problem. So S100B, GFAP, and neuron-specific enolase, three fairly common biomarkers that people look at following traumatic brain injury. You see what they're like in the control group. You see how they rise after a traumatic brain injury. And then all of these different things are ways of disrupting glymphatic system functioning. So this is a cisternotomy. This is acetazolamide administration, which is going to decrease the pressure through the system. This is sleep deprivation, so you're not letting them clear as they normally would. This is aquaporin 4 knockout, and this is aquaporin 4 knockout plus traumatic brain injury. So the issue here is these markers that we're looking at in the periphery, so these are serum concentrations. If the glymphatic system gets disrupted from the TBI, you may not be getting the clearance that you would expect, and so you may be getting a false low value on these potentially important biomarkers, making it hard to know what to really make of it. Ideally, you'd be measuring what does glymphatic system flow look like, and in some way adjusting these different biomarkers based on that, but that's not something that we currently do. And then lastly, as you can imagine, with any new discovery, people have already started thinking about how can we develop therapeutics. So some people have looked at the use of stem cells to inhibit reactive astrogliosis. That astrogliosis is part of what causes the aquaporin 4 polarization to fall apart. People have also looked at, can you use anesthetics post-TBI to induce that clearance and enhance glymphatic system functioning, just like we saw in that mouse model. And then in a really interesting study, they looked at osteopathic manipulative treatment to improve glymphatic drainage. So there are some osteopathic movements that are felt to increase the flow through the lymphatics. They looked in a group of individuals. This is Kashyap et al. 2021. These people had fairly severe head injuries. They had an external ventricular device placed that they could easily measure their intracranial pressure. And they looked at these three measures pre and post treatment. So before doing these specific head movements and after, they saw a significant drop in intracranial pressure. And these are two measures that are looking at the pupillary index and then the optic nerve. And they really felt like they had pretty good indication all around that they had improved glymphatic system functioning, or at least decreased intracranial pressure. So some concluding remarks. This is a relatively new field. It's grown significantly since it was named in 2012. There are similarly growing literature bases for aging, Alzheimer's disease, and Parkinson's disease. There's a current reliance on marine models, mouse and rat models, and there's a need biomarkers of glymphatic system functioning for us to really be able to do in vivo human research. I mean, all the marine model stuff that I've been showing you, you know, the mice are sacrificed, and they do their measuring. And from an in vivo standpoint, we really need to develop biomarkers for human research. The TBI literature on this subject is still at the stage of proving disruption and evidence of protein accumulation. And then lastly, emerging topics are influence of sleep disruption, considerations for biomarker development, and novel therapeutics. And guys, that's it. As promised, it looks like we have right on 15 minutes for any questions you guys might have.
Many thanks, Professor Peters, for this very interesting talk. Actually, it's a really interesting journey in TBI and the impact of TBI on neurodegeneration. Many thanks. Are there any questions?
Could I?
Yes, of course, Kostas.
Matt, great job. What do you tell patients now, if anything, after an injury? Is that part of the discussion yet, or is that something that you don't even talk about?
Oh, no, Costas, I absolutely do. Primarily as a way of showing them how important getting their sleep back on track is. So I definitely take advantage of this literature. I tell them, you know, we know about this pathway in the brain now. One element that we believe is true is that it functions best when you're sleeping. And so I tell them, like, when you sleep, it's when your brain has a chance to take out the garbage. And if you're not sleeping, everything is building up in your brain and it's not leaving in the way that it's supposed to. And I've had quite a few people grab onto that and really understand that, like, wow, there is actually a reason for sleep, and some of it might truly be related to my health. You know, I've had a few patients when I explained to them, is there any way for us to check and see how mind is functioning? The answer to that is largely no, but if I can get them focusing on sleep improvement, that's a pretty good start.
And so just to correlate, how far do you go in helping them sleep better pharmacologically?
Yeah, I mean, I will usually start fairly simple with our usual go-tos, things like trazodone, mirtazapine. I typically do not jump right to a controlled sleep agent. I'll usually have them connect with one of our sleep experts and try insomnia-based or CBT for insomnia first. I would say I have a handful of folks that I've tried Ambien or other medicines on, and only one of them really had a great impact from it.
Thank you.
Professor Peters, I would like to ask you about the impact of other modifiable risk factors of dementia. For instance, yeah, you mentioned the role of sleep quality. What about, for instance, physical activity? Is there a role of physical activity in managing the risk for the onset of memory deficits because of TBI?
Yeah, no, I definitely think yes. We see our patients with TBI do better with physical activity, just like we've seen in many of our memory disorder cases. If you think about the glymphatic pathway specifically, because the pumping of the heart and the pumping of blood up into the brain is one thing that promotes movement through that pathway, you'd imagine that you might actually be getting some better clearance from a cardiovascular standpoint and from a glymphatic system standpoint if you're exercising regularly. Also, we know that good exercise is going to put you in a better position to sleep at nighttime as well. So you get hopefully an improvement in sleep. And from a diet standpoint, we tend to make the similar recommendations we do in Alzheimer's disease. Sort of what's good for the heart is good for the brain. I can't really think of any specific dietary reasons that we've come up with that would connect to the glymphatic system specifically, but certainly in traumatic brain injury, we have patients that there's some disinhibition. They really stop focusing on their health in a way that you would like them to. And some of that is demoralization, the changes that they're experiencing. So, one of the biggest things we do with our, when we get our patients into the clinic, they're typically, 6, 10, 12, 14 years out from a traumatic brain injury, and they've just kind of been passed along and haven't found a provider that can really understand how the TBI part might be playing a role in cognition or in neuropsychiatric symptoms. So if we can get the motivation back for them to live a healthy life, it really does seem to improve outcomes.
Many thanks. Are there any further questions? I would like to pose an additional question. And
Sure, please.
yeah, okay, thank you. What about the impact of glymphatic dysfunction on longitudinal biomarker changes in Alzheimer's disease or in preclinical Alzheimer's disease?
Yeah. Isn't that interesting as well? I mean, I really think that our biomarker studies, if this is a pathway that helps the markers get out into the periphery, then it does seem to be one of the metrics that we need to know about when we're looking at markers. So let's say that the lymphatic system as Alzheimer's disease is starting or processing, let's say the function of it itself changes regardless of increased beta amyloid release or deposition. You'd imagine that would have an impact, and that it might actually hinder your ability to see how high some of these markers have increased in the periphery because they're not actually getting out there. So it makes you really start thinking about what are the biomarkers that may exist that would still exist or stay the same independent of clearance mechanisms. So, what might those markers be? Is it exosomes that don't change when the clearance in your brain changes? Who knows? But I think it is important to keep it in mind.
Thank you.
I pose another question.
Yes, of course, Kostas.
Matthew, you referred to your study with Michael Bray, suggesting that prior TBI changes the phenotype of dementia. Is there a practical view to that? Are you, for example, seeing someone with MCI who has a history of TBI but doesn't have neuropsychiatric symptoms? Would you be inclined to give them a preventive therapy, or how would you apply that knowledge to your care of people with dementia?
Yeah, nice question. I have not initiated things preventively in this population. I will typically tell them that if the brain injury is going to play a role, and it's that's something that I can't really predict, and there's going to be different symptom clusters that we're going to be watching out for. So, I'll tell them, like, these are the additional symptoms, maybe impulsivity or disinhibition, that might make your the Alzheimer's disease that you have look a bit different than it would in somebody that hasn't had this particular damage. Maybe without realizing it, I'm a bit more aggressive about getting on top of those symptoms in those patients. But given what we know about the benefit of treating that symptomatology in dementia more broadly, I would say I'm pretty aggressive about treating those symptoms in pretty much everybody I take care of. But I have not done anything from a preventative standpoint.
Many thanks. Are there any further questions? This is not the case. Okay. Professor Peters, many thanks for your interesting talk. Many thanks for answering our questions. All the best, and see you all in a month.
All right. Thank you, guys. Good to see you all.
Bye-bye. Bye.